Hello and welcome to the third conversation in our Let's Talk Public Health series. Today's theme is addressing violence against women as a community health issue, perspectives and pathways. Let's Talk Public Health is a conversation initiated by Azim Premji University. The objective is to learn from meaningful contributions to communities' health and well-being through cutting-edge practice and to deliberate on contemporary public health issues that intersect community health systems and policy. In today's conversation, we delve into an issue which is quite ubiquitous, whose repercussions are quite palpable. However, the questions before us are: has the public health community given the attention that it requires? Are we able to see beyond and beneath the injuries on a woman's body, seeing beyond just as a medical problem to be treated? More importantly, more than just getting angry and frustrated when we see some gross cases highlighted in the media, can we address it as a community health or public health issue and address it systematically? Given the context of recent outage in India against sexual assault on a female health professional and the ongoing violence against women in India, today's theme calls for a deeper reflection. So we have today Dr. Manisha Gupte to lead us into this reflection. Dr. Manisha Gupte will draw from her 4 decades of long work and the work of her experiences at Mahila Sarvangin Utkarsh Mandal, Masoom, a community-based organization that is based in Pune, Maharashtra in India. Dr. Manisha has a MSc in microbiology and a PhD in sociology. She has been involved in women's and health rights movements since the mid 1970s. She co-founded Masoom, that's Mahila Sarvangin Utkarsh Mandal, a rural women's organization in 1987 after residing in a drought-prone village in western Maharashtra for 5 years. Her activism spans campaigns for reproductive, sexual, and minority rights, and policy level interventions at the state and national levels. She is associated with organizations nationally and internationally to strengthen capacities in the Convention on the Elimination of All Forms of Discrimination Against Women, that is CEDAW, economic and social and cultural rights, and feminist movement building. After her presentation, I will have a focused discussion with Dr. Manisha on some overarching issues connected to today's theme. Meanwhile, please type out your questions in the chat box as the talk progresses. Our team will compile them for a larger discussion at the end. The speaker will address all the questions. In the chat box, please make your questions pointed and crisp. So welcome to you, Dr. Manisha Gupte, to this conversation. And I'm sure we'll have today some interesting insights from your talk. Over to you.
Thank you to everybody, and thank you especially to the Azim Premji University for touching on this topic. We know how important it is, how neglected it is, and yet how basic it is to our understanding of what health is, or at an individual or at a community level. So I'm going to take about 40 to 45 minutes, and Dr. Eddie, Dr. Premdas will come 5 minutes before I finish. So that's my cue to finish in another 5 to 8 minutes. And then let's see how it goes from here. So thank you everybody for anyone who's joining at different time zones. So I really appreciate that. So I have a slideshow, and I'll let's first go to just very basic concepts so that we're all on the same page. Very quickly, community is a bunch of people living within a particular geographical area. There are common interdependence issues, embodies various forms of human association with each other, interaction, some shared identity. There's some agreed norms, conventions, and rules to facilitate that social order. Now, health we know includes more than healthcare, is more than the absence of illness or infirmity. It's a state of complete physical, emotional, and social well being, and the ability to interact and cope with one's environment in an empowered manner. It has to be guaranteed by every state, every nation state, because it's a human right. So the WHO defines social determinants of health, because we know, as we said, that health is not something that you get in a health center, but it's an indicator of your overall quality of life. So the WHO's definition of social determinants of health are all the conditions in which people are born, in which they grow, they work, they live and age, and the wider set of forces and systems that shape the conditions of this daily life. Social determinants of health, as we all know, include social and economic conditions and the environment of people. They also include access to adequate, appropriate, and nutritious food, potable water, physical safety in terms of shelter and mobility, and all things necessary for a healthy life. Now, gendered aspects, as we know, are equally important. So, for example, what happens when water is contaminated? What happens when there's no fuel? I've seen in my community work that you might have sugarcane come into your village, but because it completely salinates the water, women have to walk a few extra kilometers to fill water. And as we know that caste, class, gender, all these intersect when you have to go and fill water, especially in unknown places, maybe 2 or 3 kilometers away from the community in which you live. Um, Community health, it refers to non-treatment based health services delivered outside hospitals and clinics. And my experience for the past 40 years, ever since I left the city, is largely rural. And so most of the experiences I will draw from will be from rural areas and my experience there. The community health is a subset of public health, and I would say it's the other way around too. Public health also becomes a subset of community health. It's taught to practice by clinicians as part of their normal duty. So when we deal with the health sector, healthcare providers is actually mandated. Many of them are mandated to do what some of the things that I will present today. Public health practice involves improving the health status and quality of the life of a population, and it's a branch of public health that focuses on people and their role in their own and other people's health. And it's a field of public health that focuses on the health status and the well-being of the population groups and communities. Now, the next slide, which is very important in terms of what I'm going to present today, is that why is violence against women a public health issue? Why is it a community? I already kind of elaborated on in the first couple of slides. So, why is it a public health issue? What is public health in the first place? So it's an interdisciplinary art as well as a science of preventing disease, prolonging life, promoting physical and mental health through the consistent and collaborative efforts of people and the health system. So it's a collaboration between them. And its determinants include gender issues. Violence against women, the UN defines it as any act of gender-based abuse that results in or is likely to result in physical, sexual, or mental harm or suffering to women, including threats of such acts, coercion, of arbitrary deprivation of liberty, whether occurring in public or private life. And I think this private and public life is something that we'll elaborate as we go along. Violence against women includes domestic violence, intimate partner violence, and gender-based harm against women in the public and private domains. Now we know, that it's a public issue, health issue, because it has so much commonality. There are patterns of injuries. Even if the woman constantly says that I fell down the stairs or I hit into, the kitchen, platform, there are certain patterns of injuries. There are patterns of when domestic violence or violence against women happens. In the private sphere, it's, even women who are living abroad in a nuclear family say that, now when there are phone calls from the in-law over the weekend, something happens, or the man has a all-night party with men, he's drunk, whatever happens, or it's during vacations or holidays when they go into the joint family and there's a lot of work there. Or with younger women, it may be about expectations of what she should keep getting from the family. If you don't have children, all kinds of things, the expectations of gendered roles. So there are specific patterns. There are immediate short-term and long-term consequences on the survivor. Not only on the survivor, also on children. What are boys learning when they see violence inside the house? What are girls learning when they see that? In the public domain, we know that violence happens. You know that the public domain belongs to men. You should not be there without any reason. You should have a strict timeline of when you're coming inside the private domain, where she's supposed to stay, even though that private domain belongs to the men in the household. But if you're out there, and we'll teach you a lesson. So we know that sexual harassment in a bus, girls will not report that, because immediately it's their education that gets stopped. And we know the moment education gets stopped, marriage becomes the only option that parents can think of. You can't blame parents, but that's reality. So in the public domain, I was asked many times in international interviews, that India is seen as the rape capital, and women are being raped in public. And I said, well, you're talking of one, I can tell you 10. And stranger danger, which is highly overrated, is only minuscule part of the violence against women that happens. Most of it happens in the private domain, from people we know, people we trust. But at the same time, why is somebody getting raped at 12 o'clock at night? It's because the women are out there at 12 at night. And I see this more as backlash violence. So, violence against women, old, new forms that keep coming, those have to be understood from medical as well as non medical, and as well as private as well as public issues. So, and we need to have an intersectional and structural approach. I'm going to deal with the structural approach a little bit later, within and outside the health system. And violence against women finally is also recognized as a violation of human rights. It took the Vienna Conference in 1994 to even say that women's rights are human rights. So, we are, in a way, sad that this violence exists against women, against children, against trans people, against men who are on marginalized or excluded intersections. And we're really glad that it's finally recognized as a violation of human rights. Now this is from a publication of Masoom, which draws upon the book is called Chakrabhed, which is breaking the vicious cycle of domestic violence. And we find that so physical and emotional violence take place. So ill health, we know that violence results in ill health, but ill health also results in violence. Anytime any illness is diagnosed, that's the time, whether it's an STD, whether it's tuberculosis, whether it's HIV/AIDS, whatever. Whenever it's detected, women are at a higher risk of violence. Even pregnancy is a precursor for a lot of violence in the family. So there's physical and emotional abuse. Women bear the violence. They may be taken to the hospital only when violence is very severe. The silence about the violence on part of the survivor as well as the provider, that is what doesn't allow the violence to come out. Uh, Leads to increased physiological, psychological, and physical violence. She's if she's depressed, she's not happy. My daughter's come home to stay for just a week or so, and look at my daughter-in-law, she's not happy with it, or she's not interested in sex, and that has repercussions. Or she might have uterine prolapse, which in Masoom we detect from the first to the third stage. Now we don't have any fourth stage because of our work in the community. But what does sex mean in those situations, or in pelvic inflammatory disease? And that can lead to miscommunication, can lead to violence, because sex is not talked about even in intimate partner relationships, including among husbands and wives. Unwanted pregnancies, repeated abortions, repeated illnesses and ill health, and considered useless by the family. Blamed for the illness, blamed for the infection. Even if the HIV came from the husband, they're loath to tell anybody that it came from their infertility with the male. Now these are very sad conditions, right? I mean, a person did not choose to become infected with HIV, whether it's a man or a woman or a trans person. Neither did somebody decide to become infertile. But rather than resolve these at a human level, and through compassion and through empathy and through understanding of each other, these become precursors of violence. Now, here is a map that a colleague of mine pulled out. This is not a map that we derived, but this is just to show you how the structures within the village that address violence. So, there are public meeting places, it could be a temple, any place of worship, the Gram Panchayat office for those who are not from India. A Gram Panchayat is the local elected body in what we call the, uh, you know, you know, in the PRI system. And there's a body of 11 people with the head called the Sarpanch, and therefore that is the Gram Panchayat office. There's the Anganwadi, which is the preschool center. The ZP, that's the Zilla Parishad, that is the district level in India. And so this is like a government school, and the primary health center, the sub center, the public distribution system, which is the food. And we know that public distribution system now, there hardly in my community hardly any people who have a functional ration card for the PDS, and therefore PDS shopkeepers are finding it very difficult to open the shop because they're not making any money. It's they're going in loss. So in effect, this PDS system is in a sense quite disintegrated. Now the structures and platforms in the village that we approach, the Gram Sabha. So it's different from the Gram Panchayat. If you look up the Gram Sabha, is general body meeting of the entire village. It happens 3 or 4 times. Ideally, it should happen 3 or 4 times in the village every year. It may not happen. And this Gram Sabha is preceded by what is called the Mahila Gram Sabha, where the women meet an earlier day. And that does not mean that the main Gram Sabha belongs to men, but in Masoom, what we do is we get the Mahila Gram Sabha, and the issues that get raised in the Mahila Gram Sabha, we take to the main Gram Sabha. In some of our villages now, women say we don't want to lose wages for 2 days, we can come directly to the Gram Sabha. So it all depends on the continuum of how empowered women are. Then there's the Tanta Mukti Samiti. That means it's a conflict resolution committee within the village that takes up maybe less patriarchal than say caste panchayats, but still that's a place that we can go to. There's the village health and nutrition sanitation committees, etc. And there are more more where NGOs or gender justice groups work. But these are what would be available or should be available in all villages. Now, if we see, sorry, I think I went. Yes. So I'll deal with the kind of work that we do in the community. So these are village-based interventions in WOW and suicide prevention. And the programs are connected because the local women are in leadership. And this is in sync with the accredited social health activist, that's the ASHA, or the Anganwadi worker. The women also belong to the village, and they form like a bridge between the community and the formal systems. So we have the support groups, Aadhaar cards, which land up at a woman's house. If there is any risk of the woman shouts or there's some passwords. She says if she uses this word, then the community dashes there. So the local groups, they intervene, especially if they feel that she's at risk of suicide or homicide. They immediately offer shelter for a couple of days until she's kind of relaxed and she's able to think, and then find out what she wants to do. So these are Aadhaar cards which are active in the village, and they work along with the counselor and the lawyer at the block level. Then survivors from local community work as paralegal workers in our organization, and also local women who are, most of these women are 8th or 9th or 10th grade or 11th grade, and they also work as health workers. They're able to identify cervical cancers, RTIs, uterine prolapses, as well as all kinds of illnesses, diabetes among the community. Now, the position is that merely counseling survivors of violence is like sticking a band-aid on patriarchy. We just fix the problem for an immediate issue without challenging any norms or structures. And if you compare this with the health system, then obviously just giving a drug today does not resolve the issue. Giving like a cough mixture when somebody has tuberculosis just won't work, right? And even giving drugs for tuberculosis, you have to do a lot of socio-economic and lot of negotiations within the family and the community to see that the person is accepted with respect and with dignity. Now, we also realize that local activists can negotiate the community structures better than any of us. Okay, we're like the fly in the ointment, really. A person like me is no threat to the community. It's the daughter-in-law, the daughter of the village That is really the challenge, because she's going to be living there and she's going to be changing the structure. So, therefore, women from the local community have to be in the leadership, and within that, in intersectionality, women from excluded and marginalized communities and groups, single women, Dalit women, minority women, women from NTD groups, etc., need to be in the leadership, because we cannot have people in powerful situations in leadership roles if they are the ones who are giving out the loan, they are the ones who are identifying the white discharge, or they are the ones who are listening to violence. We're only increasing the power there, and that's not good for any community health. Whereas if it's a Dalit or a poor woman or a single woman who's identifying white discharge, say in the sarpanch or a rich family, the woman from a rich family, even for that tiny moment, the relationship is equalized. It won't once they're outside the clinic, but at least marginally, for a moment, the relation is equalized. And if it's not equalized, at least we are not concentrating power in the hands of those who already have power. So we are there for social transformation, for progressive social transformation, for gender justice, and this is how the leadership works best over a long period of time. Um, so now, from the protectionist approach, oh, girls get, into, girls are harassed, in the buses, just stop their school. Uh, we have to move to a rights-based approach. So what we did was, you can see there's a safety map. This is about, the girls writing about when they're going from home to school, or when they're playing. And those red dots are where it's dangerous. Now we found that, there were gendered experiences. Just to give you one example, in the college, say in the parking lot, boys, talked of that place being risky, because they were afraid of gang wars and they were afraid of violence from other men. For women, just the presence of so many boys in a bunch in the parking lot became a risky place. Or there was a time when that road was safe, the same road becomes unsafe at another time. Not anybody on the road becomes dangerous, too many people on the road becomes dangerous. So gendered spaces, gender time, etc. So this is what we found in the safety mapping, and then we decided that, we have to create consciousness. So we started at two ends. We started with the street plays to talk about women's right to safety. Women don't need protection. Women's rights need protection. Nobody really needs protection, except, in very very specific situations, our rights need protection. And so, therefore, we started talking on violence against women and girls in public and private spaces. And then, how to reiterate the state obligation through the law enforcement, through counseling, through the police, courts, etc. And then we identified two major spaces where we could intervene. The police we were already working with. We identified the Maharashtra State Transport the Corporation, MSRTC, the Road and Transport Corporation, and that is what we decided, that, how are we going to work on safe transport, on public washrooms with lighting. Often the washrooms are very far away, because women need privacy, so there's no lighting, there's no water. What do girls do when periods, during periods, etc. And then due diligence while addressing violence, addressing and preventing violence inside the and outside the house. So what we decided was, in this situation, we 210 drivers, conductors, and depot staff went through a training on women and girls' right to safety in public places. And these are two very interesting three quotes after that training. Earlier when we saw a boy harassing a girl, we used to think it was a lover's quarrel and ignored the incident. After learning about consent and the negative consequence of sexual harassment on the educational opportunities of girls, I will ask her if she needs me to intervene, and ask the boy to get off the bus if needed. I've heard for the first time that it's okay for women and girls to travel, even if they're not just going out to school or college or work, or some very legitimate or acceptable reason within patriarchy. They have the right to safety in my bus, irrespective of the reason for being in the public space. Because, if women were there late at night, why is she out there? What kind of a woman is she? Is she a public woman? Whatever. And, therefore, she doesn't need, her rights don't need protection. She doesn't need respect. So my attitude needs to change based on this new learning. And one conductor said, if I keep quiet, how can I expect passengers to respond to sexual harassment? So these were some of the immediate quotes that came out of the MSRTC training. Prevention, immediate. So working with young married couples, we found helps to prevent violence and to foster partnership. So this is something we've been doing for the past 25 or 30 years. We call them joyous gatherings, Anand Melavas, in which they come in their whole wedding finery. We recreate the wedding meal that happens. Is very simple. Our wedding meal is just like one or two, one carbohydrate, one sweet, and a dal or a sabzi. That's all that is served in the community. In the village weddings. So something like that. All the fun around marriage. What we also do is that we use this opportunity to encourage tenderness. Many times, why did you take a stand? Just because she took a stand, stand in terms of as simple as getting a particular item in the shop cheaper than what he bargained for. And she said, well, 10 rupees less. Well, that was his ego. I mean, it can be anything. You have to remember that, most times both are adolescents or just very young people. He's about 20 or 21. She's 16 or 17 or 18. And so, therefore, it's largely sibling or friendship kind of quarrels. But because of the gendered nature or the patriarchal nature of the family, a small thing can result in the girl going home and never brought back. And we have to be very careful that those moments are avoided. So we also talk of contraception. We talk about laws related to gender equality, government schemes. We prevent bigamy by registering the marriage immediately. So she knows that her rights exist. We talk about sharing household activities, because even if the boy is helping the mother or the sister at home, suddenly when the wife comes, they don't want him to participate, because she should know her thing, and now she's here, we don't need to do any work. So it's not that I want to help her. And the shared joys of child rearing, the shared joys of chopping vegetables together, or filling water together. So these are things that we talk about, and these are all through fun filled activities. So there's no lecture. It's a lot of fun. If you see in the lower thing, you can see teamwork being built, jigsaw puzzles that they do as a team. So they that is something fun, and the man eagerly looks forward to the bride, the young wife, participating. There's some very sweet responses after these days events. Now, so the girl says that I was in terror during my wedding because I could hear shouting related to dowry demands outside the room. And today, my husband shared with me for the first time that he was equally scared about the wedding being called off. I feel close to him now. Today was more relaxed than my wedding day. It had all the fun around the wedding without the stress. Then another newly married woman said, I know whom to contact if I face violence at home, and now my husband knows it as well. I don't feel lonely now, and I can talk to my husband, or then I can come to Masoom. And the last one is really, one of my favorite quotes that I've heard over the years. He says that on my wedding day, I had an arranged marriage, and today I had a love marriage. I think these are huge shifts for men to come out and say things like that. So resolutions related to child marriage and Bal Panchayat intervention. So we start working with children since they are in grade 3, and then later on they come to our youth groups. So you can see that children are putting together resolution about child marriage. They've also put in resolutions later on. You'll see about sexual harassment happening in schools. So, because most marriages are arranged by the family within an endogamous caste group, delaying child marriage requires a commitment from the entire group. Because the ones who go earliest to fish catch the most eligible groom or bride within that small endogamous group. There are not too many eligible grooms or brides at the same time. So this is something that everybody has to agree, and that's very, very, very difficult. Getting elected representatives at the Gram Panchayat to pass resolutions in the Gram Sabha, that's the general body meeting, empowers adolescents to resist early marriage. See, you all pass this resolution. Now I'm telling you that my sister or the neighbors are planning, the wedding of their daughter. So the children's program of Masoom elects through secret ballots an equal number of girls, 5 girls and 5 boys, in the different committees, educational committee, recreational committee, etc. So these committees to the Bal Panchayat, that's the children's council. This is not this doesn't have a formal or legal kind of status, but it's very interesting how the Bal Panchayat has got all the 11 members to sit there. Also the revenue officer, the local revenue office, and the Gram Sevak. who's the secretary to the Gram Panchayat, all 13 of them together, and have sat there, and very interestingly, they told us that no, our mothers cannot come and speak on behalf of us, because you say that men cannot speak on behalf of women, so let the women sit at the back, even though they may be Masoom activists or our mothers. So they've conducted these Bal Panchayat meetings along with the Gram Panchayat often, and they have raised issues such as sports equipment from the village. Why should Masoom give the money? Why shouldn't the village give the money from our fund? Outdoor games for girls, volleyball, etc. Sexual harassment or corporal punishment in schools, all these have been raised with Bal Panchayats. And they've also intervened in enrolling children from itinerant groups, or those who have children who have dropped out. The next slide also is about petitioning about sexual abuse in a school, and this whole thing is about the women's group talking. So they say, that the managing committee of the school was upset with us for raising the issue of a teacher touching girls inappropriately while distributing or collecting papers from them, touching shoulders, breasts, etc. The committee members informed us that we were no longer welcome in the school to conduct our value education. Every 15 days, Masoom goes there to talk about constitutional values or peace and gender equality and love and compassion, etc. We were no longer welcome. Now, after the chairperson of the committee further threatened us that we wouldn't be allowed to step into his hamlet, the Wadi, in which there are about maybe 25 or 30 houses. If you can't enter that Wadi, once he told us that, we thought enough was enough. And so we decided to hold the next women's meeting right in front of his house. The women from the neighborhood agreed with our position. Women from his household also joined us and invited us to sit on the porch. Don't sit on the ground in the dirt outside, come and sit on the porch. This angered the man, and he was bathing the cattle. He started complaining loudly to the cattle that, there's no longer respect in the family and what was going to happen, and, the women were no longer in his control, etc. And the women obviously said we had to, we didn't know whether to laugh when he did that. Now, suddenly, his daughter confronted him, and, she said that, don't behave like this. And she said that that teacher's touch made her comfortable too. And this brought about a complete change in the chairperson's attitude. He was completely shocked. The women's group gained his support because he started believing them, that it was not something that the women's group was raising just to create trouble for the school. And after a period of inquiry, the teacher was transferred out. Now, the women's group was not very happy with the transfer. They had hoped that, he would have been suspended because he would now continue to abuse girls in another village where a strong women's group may not be present. So this is what they petitioned again. Now, the next couple of slides are, engaging with the health system. I put the backdrop of all the things that keep communities unhealthy, and so the pathways are, engaging with ashas. This diagram, represents about 8 or 10 years of Masoom's work with just recently published report on our work with ashas. And so these are the different places where the asha works. It's the Anganwadi worker, the different committees. Many of these structures are Masoom structures, but the formal structures also. You have the government systems, the primary health center, the sub center, the police station, safety planning, including shelter homes, and non-health key stakeholders in the village. So engaging with the ASHA, who's also mandated to deal with violence against gender-based violence, and with Anganwadi, because we know that picking up or dropping children is gendered. Women go there, and they are very young women who go with their 3-year-olds or 4-year-olds. They are barely 22, 23 themselves. So that's one place where, children also talk about what's happening at home at that age. So, as I said earlier, these two are the bridge from the community to the formal systems. Jan Sunwais, we've had people's hearings from maybe 200 to 800 women coming together, where violations in labor room violations happen, or denial of services happen, or discriminations happen based on various intersections. Single woman is pregnant, or a woman from particular caste, or or whatever background, and so therefore there are discrimination. So all those talk, because this is largely from the rights-based approach to demand accountability and fulfillment of state obligations related to health and gender equality. Now, the screening of cervical cancers, uterine prolapse, RTIs that I talked about earlier through Masoom's health rights program, also leads to a lot of disclosure about violence against women. Why is the white discharge, erosions, women usually will cry, especially when women are encouraged to look at their own vaginal passage by the speculum and a torch and a mirror. And when they see that, and they many times women break down during the examination, and maybe and then they talk about what's happening in their lives. So gender discrimination in the self management of diabetes also, like if a woman, who's going to give a woman a good pair of shoes, or the fact that she doesn't burn her hands, and so what happens, what happens with the daily stress of managing diabetes, like a chronic illness like that, and having no familial support or no community support can really render a person helpless, frustrated, and completely lonely, even if she's part of a big family. So all these become evident, and a survivor-centered approach that brings together the health, law enforcement, counseling services, and community structures for a coordinated response is essential to address and prevent violence from a rights-based social justice and also obviously public health perspective. Identifying risks of self harm, suicide, or homicide among women and adolescents is a crucial intervention for community well being. I don't know what's happening in your areas, but we're finding a tremendous rise in suicides of very young people. Earlier, we found suicides largely in young married women, but now we find it's boys, girls, both. But girls also. Various reasons. I'm not going into those right now, but various reasons, and we find suicide attempts and also suicides that are taking place. And through the Maharashtra Mahila Arogya Parishad that Basun helped to initiate in Maharashtra in 2006, we're also finding that even in Adivasi, that's what we in India we call tribals, even in those regions we find that suicide have increased tremendously. And so probably it's a collective reasons why this is happening, and people are just not able to cope with so many things that are happening, including the way that digital technology has come in, or the opportunities that people have of meeting people from other communities or castes or religions when they travel out, and the family doesn't know how to deal with them, especially if that becomes a romantic alliance or a sexual alliance. Also children now know more than their parents do, and parents don't know what to do with children who are more scholastically educated than them, or are still unmarried far beyond the age that they were themselves married. So parents are also grappling with all these situations. Now, this is also from the work related to ASHAs and a report that we published recently. So, this is what ASHAs said. ASHAs, are there in the community. They know violence that is happening there. And, so these are various things that ASHAs said should be done. They said health services should be geared to save the survivor's life. They should not wait for the police if the violence is severe. Giving health care is the duty of the health services. A counseling center at the PHC level is required where trained doctors and nurses can work in a team. There should be a space for women to talk about their concerns, and there should be privacy to be able to do that. Health systems should perceive survivors of violence as humans and provide services accordingly. And health systems should not be biased against any person or any community. The next slide is also of our work with ASHAs. So now, what are the things that we can do? This is what the Asha said. Audio messages to village level stakeholders on violence against women and related issues would be helpful. A helpline for survivors of violence and also for Ashas who face backlash. We know that women in the health system, especially as you go down, go to the auxiliary nurse midwife, you go to the community health worker, these do not belong to the same elite caste or class, backgrounds that you find doctors from. And so, therefore, you find the backlash from the community and also you find backlash from their families. Accompanying Ashas wherever the survivor needs police intervention, including at the village, because, so if somebody accompanies her, that would be really good. And Ashas themselves have accompanied survivors to police stations. Police staff should be oriented about violence against women and mandated to support the ASHA. An intervention in violence against women has to be done at the community and village level too, because the understanding of access to justice or what justice is for a woman, the courts interpret law. But for a woman who wants justice, that's not enough. She would like her husband to come in front of the village and say, I should not have doubted the paternity of the child, or I should not have done what I did. For her, acknowledging and vindicating herself in front of the community or family is really what she considers justice, which doesn't mean she has to be thrown out of the formal system, but along with that, this is really what the woman wants. And meeting with key stakeholders in the village to convey that violence is not a personal matter but a social issue. Now, this is not something that I or Masoom said, this is what Asha said. So you can understand how cognizant and how creatively and also how deeply they are engaged with dealing and with addressing or even preventing in many ways violence against women. Now, this is something, these are two very interesting examples of, just a survivor of domestic violence and the elected head of, so I've titled this as Women's Empowerment and Men's Active Support in Gram Sabhas paves the pathway to a gender equal and gender just community. So when a survivor stood up in the Gram Sabha and talked about her domestic violence, everybody trivialized it. And, it's a personal matter. It's only about you, and she was very empowered because she was part of a self-help group very associated with many of the CBOs that Masoom started. And she said that you say that the beatings are normal and it's my personal issue. You think I have no power as a daughter-in-law of this village? But what if all the daughters-in-law of your village walked out of this village this very moment? Where would you be then? And I think it was a remarkable and absolutely brilliant, way in which she did that for various reasons. But I will talk of two. She brought about the story. I mean, we are, we are poor, or, we have no power, but we are so many, and it was the safety of numbers, and she got everybody to rally around. So what would happen with the village? And also in that one, what she did was she connected with her mother-in-law, all the mothers-in-law in the village, because they were also daughters-in-law of the village at one time. So this is kind of consciousness that people will display if they have a safe space and a secular space to talk about it, not just a caste panchayat or a religious based group that is talking about that, but a more secular space where it's possible to talk about these issues. This is about a sarpanch in a village, and he's very, very otherwise very, he's wearing the dhoti and the topi and stuff like that. In that sense, unsung kind of a person. And he talked when he talked, was speaking from the stage. There were about 400, 500 people, maybe more than that, in the audience, and he said, "Why do we normalize violence against women? I have been married for over 30 years and I have never raised a hand to my wife. There's no heroism in beating a woman. Try to behave decently and see how much more enjoyable your life will be. No boy should grow up seeing violence and thinking it is normal." Having men from the community stand up like this and speaking publicly, I'm not just talking of powerful men like this man, because if you invest power in a powerful man, in some other ways it's going to be much more difficult for you. But we hadn't planned this. He just, on his own spoke in the village. And when men in leadership fulfill their social obligation to denounce violence, they also strengthen the possibility of gender just community and society. Now, this is something prevention. I'm coming to prevention now. Homes and land on women's name, because we know that the hallmarks of patriarchy are to keep women bereft of property rights, inheritance in the mother's house, so they have no option to get married, and not giving access or right to property in the husband's house, where she has to stay and come out as a dead person. So we used a government resolution. It was long lost, hidden. Government officials at the local level didn't want to share it with us, and the co-convener Ramesh Howe unearthed that, and we converted over 12,000 homesteads on joint names of husbands and wives. And even if this resolution just dealt with, we know how limited it was, married women, the impact was tangible. Men, especially older men, used to wait for us sitting on the roads, saying that, please convert my name to joint, because if I die, when I die, my sons will throw my wife out of the home. Nameplates with both the names. You can see both the photos, the couple with the red nameplate, and, a nameplate being, given by a Muslim colleague to the couple. So, and this money was taken from the village fund for women and children. So a woman says, when my drunken husband told me to get out of the house, I brought him outside and showed him the nameplate. Don't forget, it's my house too, I reminded him. Women's ownership over land is a bit complicated because it's still three generations owning the land. So we are working on that. With over a few hundred applications are there at the block level. We've given a typist and a data entry person to the local government, but we haven't been able to convert more than 100 land pieces, clear titles for women. Now let's talk of the challenges dealing with old and new forms of violence. We have to address overt, covert, and structural violence. To be structural violence is patriarchy, class, cis heteronormativity, able-bodied hegemony, etc. So all these we have to deal with together. In India, we cannot deal, with that. We know all these structures are completely related to each other. Old and new forms of violence, including backlash violence, have to be addressed. Cultural and religious nationalisms, especially violent single identity politics, increases patriarchal hold inside and outside the house. To create a violent man at home is going to be violent outside, a violent man outside the home is going to be violent inside. It encourages toxic and violent alpha masculinities, and it fragments communities. It's very sad for us when we see children who have grown up together now, kind of have distancing from each other because suddenly there is, a particular identity that they see as their major identity. Othering also, we know, increases violence against women. Our women, their women, polarization among people has increased. We need to work with families, communities, starting from children and young adults. Privatization of health services, education becoming unaffordable, failing agriculture due to unseasonal rains. This past 1 year has been absolutely devastating for our farmers. Shortage of drinking water and fuel, unemployment, recurring water, vector-borne illnesses. All these what we had earlier now have this name, and they're scary. All kinds of vector-borne illnesses are coming with a vengeance back. Early and child marriage seen as a solution to any disaster or crisis all impact the health of individuals and communities and harm women. So violence against women becomes a routine time in times of stress, or suicide increases even among young people. Communities and neighborhoods are disintegrating. Development projects, so you're coming to the city. Distress migration, it's not aspirational migration, but distress migration really fragments a community. We need to be mindful of very popular common sense response to violence against women in the way that we have a fragmented society right now. Discourses around love, live in relationships, women's mobility, reconstruction of a good woman through a religious and cultural discourse, and women as repositories of honor of the communities. We also need to change the notions of honor from being external and retributive to internal and ethical behavior. So we have to keep saying that families and communities lose honor when they perpetrate violence and not when women speak out. Yeah. And I don't have the time to talk about the example, but there was public transport in which girls were being sexually harassed by boys coming from another village, and the first response was, let's stop the girls education, let's stop. But when they talk to the community, we said talk to the village in the other and say that this is happening to our girls. The girls can't enter the bus because the boys are just bullying them and sexually harassing them. So this community, they went with the girls and spoke to the other community, and that community said that this is terrible, we cannot let our boys do something like that, and both the villages came together. So I think this is something changing what the notion of honor is. Honor is honorable behavior, and not being just laden by guilt or shame, but by intrinsically being a good person. So then, healing communities, challenging myths, norms, and structures. We have to challenge the artificial divide between public and private domains. So, for example, when a village level health worker enters a household for immunization or during COVID or whatever, it's her public domain, but it's the private domain of the woman whose house she's going in. So this completely ridiculous division, artificial divide. Or when a woman goes to fill water, it's in the public space where she's encountering all issues of caste and class and everything there. Also being expected to fill water in the shortest amount of time, and working in the husband's farm. Yeah, thanks, Eddie. That this means that I have about 5 more minutes to complete. So thanks, Eddie, for coming on. We have to challenge the belief that violence is a personal or a private issue. The state obligation to respect, meaning that no state or state representative can violate or perpetrate violence. protect is to see that no non-state actor also perpetrates violence, fulfill and promote everyone's well-being. This is something that we need to iterate. Access to individual and social justice, as I said, that goes beyond the law enforcement and legal distress to see what women see as justice when they are harmed. And often women want to be vindicated in the presence of their families and communities. Challenge harmful practices embedded in caste panchayats. We have gone and stopped caste panchayats where women were told to put their hand through boiling oil. If you are chased, do that. And so they pitted. Many people are drunk in those caste panchayats. So that is something that we need to do. And we have to create secular platforms available for access to justice. Challenge the notion that the human and constitutional rights can't enter the private domain, and that violence against women is not a private affair that needs to stay inside the private domain, it can come out. And many, because many private domains make the community, right? Also challenge the community norms around pregnancies outside marriage. Why can't a girl continue her education? Or also the fact that what happens when intercaste or interreligious marriages happen now, whether you like it or not, these things are happening, and what are we going to do with the our children who are meeting other people? And the response has to be humane and it has to be empathetic. So about gender identity or same-sex relationships, often the community is the perpetrator in this kind of violence. The family isn't intervening, so now we will intervene as a caste or as a community. And then challenge private and public patriarchy. So there was this thing about now, in because of the PRI, the sarpanch, when she's a woman, the husband now has become the sarpanch pati. This is a new kind of a phenomenon, a new animal that has suddenly, been born. So in a particular community, when the man was sitting on the sarpanch's chair, and our women's group said, "No, Tatya, get down from the chair." The woman was at home. They called the sarpanch, made her sit on the chair, and they told him, "You don't need to sit in the hall because you're not an elected representative." So this is the kind of empowerment that once the community comes in. And this is the last slide. So, what is the pathway to a healthy community? Substantive equality, focusing on education, gainful employment for young women, because women can't stay outside the village for very long. We have to be inclusive, non-judgmental, but women come to us for justice within that relationship, right? So they if they have to choose between, they will choose the family. And how do women change through this process in terms of not just to fix the problem and but rather challenge patriarchy? So how do they deal with, are they empathetic to the other women in their families? Do they challenge patriarchy beyond violence? And do they become agents of change? And one of the things that we tried was getting survivors of violence as our paralegal workers. Prevention is the key. Property rights, gender equality, non-violence inside and outside the house, changing men, working with young couples, children, adolescents. Now, methods have to be different, right? Our methods have to be non-violent, they have to be empathetic, they have to be feminist, not merely woman-centered. Get the other woman out of my husband's life and, fix my life. No, that's not the way that we do. Or charge my boyfriend with rape because now he's refusing to marry me. No, that was consensual relationship. So it's not just woman-centered or pleasing the woman, but challenging patriarchy. We challenge caste, class, patriarchy, majoritarianism in whichever country that we are in, ableism, heteronormativity, and all systems of exclusion that we need to challenge. Because I want to end with this one sentence, that structural violence and discrimination are the fountainhead of unhealthy communities. And if communities have to be healthy and work along with health systems, then we have to see that the structural reasons why violence happens inside families and communities needs to be challenged. So thank you very much. Thank you for your patience.
Thank you, Manisha, for such a insightful, exposition of these pathways and understanding the gamut of violence that we experience. I think it's quite fabulous to put this on single platter today to discuss, because quite often we think violence means only some gross incidents of what we say when there is a lot of media attention and all that. But you have laid out from an individual, community, family, the psychosocial violence, the emotional violence, the unsafe feeling of unsafe, as also violence, So that is and to to also to the public institutions, how violence gets embedded, in the way the public institutional behaviors, public behavior, collective behavior. This is, I think, a kind of a very broad spectrum of violence that we have today, you have laid before us. And what came across very interestingly is that the pathways to address, generally we assume rights means like you empower the individual, but all across your Masum's work and your own work, what came across was that a kind of a public and social accountability that needs, it is the from moving from protectionist to rights based kind of a approach. It is not happening only in the individual's empowerment, it is also societal accountability, of ashas, of gram panchayats, men, and of systems. That, I think, came as very very strong markers of addressing violence. And also you touched upon your I'm sure each is a story by itself, how you could work with panchayats, how you could work with men, how you could work with young children. So it basically tells us that it is such a pervasive and structural issue. One needs to look at broad spectrum of various aspects of community and societal life. And the first point of that today's discussion that we have is about how do we recognize it, because if you do not recognize, we all think it is normal, the normalcy, making it normal continues as long as we don't talk about it. So I think we have set a path today. By first is to, in public health itself, you look at it from a public health point of view, the interconnections between illness and health and violence, they're all interrelated. Because I remember quite often where earlier when we went to Baba Hospital to see the Sehat's experiment, I'm saying the kind of experiment in training doctors and medical professionals to identify violence. Whenever women came, they only treated them and sent them away. But when the violence and public health issue came, lens was given to them, they are asking further questions. I'm saying, how did it happen? When did it happen? You have come for the third time. What is the so these questions themselves, we make us recognize this issue. I think thank you for this very wonderful, insightful discussion. We need to have more of it. And I would like to just now have a small conversation with you on other aspects which are around this. As you know, recently in West Bengal, Kolkata's that incident of what you say, the medical professional was assaulted, and it has gained a lot of attention in the country. So we also see violence by various even people. When they go to the institutions, they experience violence. What we saw, let's say one example, labor room abuse, what they call, they feel psychosocial violence. Similarly, we see violence on medical professionals for various reasons. We see different kinds of abuse by health professionals on people. So at a one point in time, it looks so pervasive, and though some of these incidents catches our attention and on the media because the grossness and the severity of that. But I feel, or it comes across from your presentation, that violence is not only these incidents, but it is all pervasive. I would like to want to know about how do you look at it. How do you reflect on this, in the institutions people? Do you also see the same way? Do you have different experience in your work? How do you place it, when in the discourse of violence that we are having today?
So the various like we find what happened in Kolkata was absolutely so shameful, and it was we had to hang our head in shame to what happened, or earlier incidents that now these terrible ones come out, and often they come out with empathy. I heard that the Pujo festivals in Bengal or even in Pune, my colleague was saying, didn't have the same enthusiasm from Bengali communities because they were just so upset and so sad and angered by what had happened in West Bengal. So all these things happen, but there's a violence that happens on a regular basis. Yeah, and it happens upon doctors. Misogyny exists, our uh, uh, women doctor friends talk about, how they were so uncomfortable, interns, residents, so uncomfortable when, the boss walks in and talks to women patients in a completely, disrespectful manner. Or, the examples or the jokes probably that have come down over 20 years, the same jokes are cracked and they don't know what to do, and they don't know whether to look at each other, and that becomes normalized in the residents that are following the doctor. So this is something that is happening. My experience, as I said, is largely community based. I'm a community based person. Violence. So Sehat again has done studies on violence and discrimination of or violence on healthcare providers, especially ANMs and ASHAs. So this violence comes from various, the family, the health system pushing them to say, why aren't you getting so many cases of sterilization? We know that Manda Padwal, an ANM, years ago in 83 or 84, committed suicide on the 27th of March because she wasn't able to get the adequate number of people for sterilization in an already endangered population, where the numbers were falling of people. So this happens from families. If she gets any extra money after sterilization, where did you get the money from? Which man is providing you the money? Why are you with the doctor or the driver in the jeep? If she's not doesn't get money because her salary is cut, why haven't you given me the money? Many times he has another wife because she has a transferable job. So these and the community. So for example, when a government scheme gets announced, a particular amount gets announced, that's not the amount that comes to the villages, or it's all tied up. And unless this happens, that doesn't happen. But people don't understand that the people who are who see the health providers are the ashas there, or the anganwadi workers, and they have to suffer a lot of violence from the community. So this is all pervasive within the health system, and from the health system to the people, in terms of telling half truths when you have to take somebody for a sterilization. There, as you said, each is a story that can be written
Yeah,
up. So this is really horrible, and it's only the violence that is so horrible and gross that we talk about. But there's violence that as we speak, the violations are happening, and that's really
correct.
really something to worry about.
Yeah, I think this is very important to recognize that violence is not only some episodes, but it is a continuum and all pervasive. That brings me to another point. You so see when we work with the communities, as you would have definitely experienced, quite often we recognize or we understand that the root causes of some of these issues are upstream. They are not in the community. For example, we have seen women's deaths in sterilization camps where the community members themselves, ASHA, ANM, others, are forced to, to meet targets and they bundle up women. But then women can't see. We have seen sometimes of the communities where, let's say, medicines are not available in the primary health center. They're siphoned off somewhere else at the beginning. But a person who goes to the PHC only sees the doctor or a pharmacist in front of them, and there, you do not have the medicines. Then that gets into a kind of a argument and goes up. So quite often the communities can't see this, what we say, what is lying somewhere beyond the vision, the root causes. Have you experienced of such kind, or how do you communicate this to the communities or to the women that would train or leaders, and also help them understand that multi-level action is required, or how do we go about when we recognize that the roots are not only here but elsewhere?
So I think one of the issues is transparency, and one of the issues is empowering people with information. So you talk to communities, community meetings, get all the ashas, get all the ANMs on your side, even the primary health center doctor many times on your side while you're talking, and explain why certain things are not possible. If like three posts are not filled, like in say in a rural hospital, you have a surgeon but you don't have an anesthetist, or you have a psychiatrist with no other support, with no basic services available at the rural hospital. What is the psychiatrist supposed to do on his or her own, and what is the anesthetist supposed to do without the surgeon, or the surgeon without the anesthetist? So all these things have to be explained to the people, and then to tell the anesthetist and the psychiatrist and the other doctor, you also have a basic MBBS degree, right? So it doesn't mean that you
Mhm.
have to sit just in your ivory tower and say, I will only deal with, emotional issues. I will only deal with gynecology. You can also do other kind of stuff. Also, educating health workers. So I remember in our health education to say that, after immunization, if somebody, if a baby has mild fever, actually that's a sign that it's working. Yeah, it's an immune response. Now they would hide, they would not tell parents that, the child may have mild fever, and people would not
Mhm.
come for the next immunization. Now, talking about this and telling people what the possibilities are, or also talking to people about what the risks of that particular immunization may be, or the risks of, what COVID are without immunization, vaccine or with vaccine. All these things, if you talk openly to people, many times it's just basic lack of
Mhm.
communication. And now we are finding that,
Right.
when people die in hospitals, grief management doesn't exist, and therefore then that grief comes out in the form of violence against health professionals also. So I think transparency, talking to everybody, empowering people with
Okay.
information and policies is very important.
Yeah, and you said a constant opening for dialogue and communication, transparency would be a good way to, I think, bridge these gaps. That brings me to another question since you raised about medical professionals. Do you think, now that we have a 75 years of history of medical education, training health professionals, uh, do you think our public health education or medical education has sufficient space to think about these issues of violence of various kinds of, and at least women who are center to medical treatment, medical care? Or do you think what can be done about this? What do you think? You have done quite a lot of work with professionals as well, but at this point in time, since violence has become the center of our discourse of different kind, when medical professionals also are experiencing saying that violence is not good when it happens to them or to the others, what are the ways you think public health education can bridge this gap? What needs to be mainstreamed? What needs to come into focus, both in public health and medical education or education of healthcare professionals?
So there are various sections. Now, let me start from the community. Let me go there. Talking in the community about, why violence is a health issue and why health, and what do we mean by healthy community? Which does not just mean lack of illness or infirmity in the community, but much more. And how do we define that? That's one end. Working with the healthcare professionals in terms of, the kind of violence they face, or the kind of, situations in which they are thrown with no recourse to backlash. So when they face backlash, also bringing out the state obligation that, you are mandated to do ABCDE. And what happens is, like,
Mhm.
the Asha is like the youngest daughter-in-law in the village. So the moment dump, earlier it was the ANM, now the ANM has now another, younger woman in this whole joint family of the health system. And so the Asha is just, whatever happens, give it to the Asha, whatever, everything, just
Mhm.
load.
Mhm.
What about the
Yeah.
issues that she's facing in the community? So I think those, and then gender in medical education. We talked about Sehat's work that has done on GME, or also in terms of ethics. Why is it not part of a compulsory education? Or why is gender based violence not like, for
Mhm.
example, DSM may say that, obviously, I mean, being trans, or having a same sex affection towards somebody, or attraction, is not a disease, but that's what happens at the level of the clinic. And you are not only,
Yes.
you're scared, you're frightened, and you're ill, right? And then privatization also, no, Eddie? When, it's the poorest, when they are ill, who are standing in that line. How can public health services get better? And you have to declare a dog mad before you can shoot it, right? So the easiest way is then to
Yes.
start privatizing, though we know that privatization doesn't work. So public hospitals have private, I mean, these are also structural violence, right? You go to a government hospital, but you don't get stuff free. So different kinds of violations that, and rights, patients rights, I think, you have to work continuum from the community in which there are the patients, the health system, and back to the community of patients, and trying to see how everybody understands that violence cannot be justified. You can be angry with somebody, you can be upset with somebody, but you cannot be violent.
Yeah. Thank you for that. I think we need to reflect much more on, I'm saying, how to mainstream, sensitize or bring it to a, it is not a, anecdotal or side issue. It's like how does it become part of the mainstream education itself? Sensitivity, ethics, and addressing, violence. This is very important. There is always a dilemma that we come across, when we speak about women's health, especially, and violence against women, because it leads to, the health repercussions. One is about, we know that women of certain age, reproductive age, are focus of our health policy all the time. It begins with puberty, and when till the woman stops reproduction, either by sterilization or by menopause. So this is one part, is that this is important to address. But there are others who have also said that the women, the female, generation, that is before the puberty and after menopause, they don't exist for the health policy at all. So that is also where, where the violence issue, and that falls, because it is not part of a reproductive health part. So it is a dilemma that we start addressing. Yes, maternal health is important. At the same time, it is other things, not that they are not important. Now, this dilemma is posed in different ways. We know that we have a lot of research on maternal health, reproductive health, a lot of people working on that, making it better. At the same time, the addressing issue of violence is falling in the cracks. It is not part of the policy. There is no health professionals addressing that. Now, do you see this wedge or this divide, or do you think somewhere these bridges are, are built, or there is a kind of a synergy happening, or it is not happening, or what is your view on that? Is it both are important? Do you think now prioritizing reproductive health over women's health is a compromise? I'm just wanted to get your thoughts, having so much time that you have spent in this field thinking about it. What are your views and perception around this?
Yeah, obviously, there is no binary and there is no one way that we do. One of the issues, one of the problems of funding or going just for project-based funding is that you focus on a particular issue, and sometimes the pressure from the donors is so much, or from the state is so much, that just to get this done, it becomes very difficult. So obviously, we cannot
Mhm.
see anything in but yet we have to put the word S in SRHR, right? Because otherwise sexual health issues or sexual rights do not come. Like we used to say, put the M back in MCH, put the mother back in maternal and child health. Now families and health systems and the state market, everybody manipulates women's reproductive labor. Yeah, so for the family, she must have children, at least one son or two sons ideally. The state and the family also will find that if her hands are hurt, she'll be brought faster to the health system because those are required for work. But if she has white discharge, it doesn't matter until things go really out of control. In the health system, it's not even up to menopause. It's just those 4 or 5 years. You get pregnant for the first time, that also within all the confines of marriage, etc. If you get pregnant outside marriage, there is no way that you can go and access an abortion, or you can go and access antenatal or postnatal care, or for a woman who is deserted or widowed to access contraception. So these are also violations. But the state is interested in your two children and then the sterilization. In 1987, through FRCH, and through the commission that was working on working women, the Shrama Shakti report, we had done a study, and in 87 women had said that once sterilization happens, a hysterectomy comes within 5 or 7 years. And they said, that the at least the older sister doesn't wash your house away, but the second sister, you go in complete debt. So this is what women talked about. And until sterilization, the public health system does everything free. In fact, there's incentives, disincentives. Our poorest women cannot become elected representatives, can't have access to maternity benefits. 2% of women have maternity benefits in our country. Rather than universalize those, you take away from those who already have, or cannot, don't, the third child doesn't get, any benefits, BPDS, etc. So in this situation, the state is saying two children, uh, family saying at least two sons. So this is the way that they are manipulated throughout. Now we know talked of labor room violence in the beginning. So I was saying earlier that until sterilization, it's the public sector, and then suddenly the uterus becomes a useless organ, and then you have the private sector step in, and then the hysterectomy happens.
Mm.
Anyone is going to have some menstrual distress throughout their menstrual cycle from the age of say 12 to 45 or 50. The simplest thing is remove the uterus, because then you don't need to deal with taking pills for religious purposes or whatever. It's just kill two birds, but that bird, the burden is borne
Yeah.
by the woman. So reproductive, again to reiterate, reproductive and sexual health and rights are very, very important. They cannot be seen outside the gamut of as we live
Okay.
longer, as we outlive their ovaries, there are going to be so many other issues that we haven't seen before, and it's a
Right.
continuum from childhood to old age.
Right. Right. Thank you for this. I think it's a very important discussion. We need to have much deeper and much longer. But this insight is very, very helpful in placing this, issue in the context of violence. We have some questions from the floor. I will read. One is a comment, the other one is a question, which is related to the accountability and masculinity, in the health system. So this is from Mahendra Kumar from Mitra from Bundelkhand, Uttar Pradesh, who has worked with masculinities. The question is, I will read out as it is to get a sense. Questions related to accountability for addressing violence against women as community health issue. We will need to ensure public accountability along with social accountability. This is a comment, and followed by a question. Masculine attitudes of health institutions and men's behavior increase the risk of women, while they access healthcare. How it can be addressed? Similarly, masculinities in healthcare institutions is an important issue that needs to be discussed. How to use the digital technology in health? Is it possible to end violence against women? So, similarly, around the issues about masculinity in the institutions, which affect women in terms of not going to the public health institutions, or when they go, they feel unsafe and they see a sense of violation of their rights and violence itself. And what are the pathways? Is there a way to use technology in this? Is a broader question that is posed before us.
No, yeah, no, thank you for the question. Definitely, I would say more masculinist, kinds of attitudes harm women, children, trans people, also men from marginalized and excluded communities, because this masculinity is not homogeneous, right? It's you can exercise your masculinity only if you are from a particular section. Lot of men cannot exercise it in the public domain. They will in the private domain, but in the public domain, their masculinity doesn't really mean anything. So therefore, definitely it has an impact on violence. As we said, impact on their peer or their other colleagues, the women in the health system, on patients, in the way that you interact with patients, or in the way that you interact with the communities. Of saying, that this is useless, this is, we're not going to provide health services, or you are from another primary health center area, so don't come here, because for sterilization you'll go to another. So I think these are different violations, and to understand the pressures, as you mentioned earlier, I've lived in a very tiny village, which had the access of only one public bus coming in the morning and at night. This was in the 80s, and we have seen
Mhm.
how doctors suffer under the pressure of sterilizations, and because we live there, the kind of sharings that different health workers used to do. So it's this masculinist attitude, that is getting more, and as violence becomes more normalized, and violence becomes more through film media. Look at so many of the films that are talking of this kind of unabashed toxic masculinity, and this is what women love. And women's no really doesn't mean no, because they don't know what no means. So all these things will definitely affect, there is no doubt, and I'm so glad to the friend who raised this issue and made the connections. Digitally, of course, now digital has democratized in some ways, where what was available to me in a smartphone is available to somebody else on a smartphone immediately. Yet we have to understand the gendered aspects of who holds that phone. If you're doing banking, who can now use the password on the phone to withdraw money from the
Mhm.
account that you have. So digitalization also requires further democratization. It creates a false impression that I have everything in my hand when I'm dealing with, because when digital people are most at the most, it is a smartphone. They are not exposed to or don't have access to the other big kind of digitalization. So until we democratize that, and
Right.
we also see that gender and otherwise people have, otherwise you think you have the whole world in your hand. Actually you are being controlled
Yeah.
by the community every moment that you have
Right.
been. Work from home for women is quite different from for work from home for
Right.
men, right? So with this
Right.
digital, you have to respond in a minute, right? The moment people see the two ticks on WhatsApp, you are expected to respond. And knee-jerk reaction sometimes can be so wrong, isn't it? So
Mhm.
what we require is a require again, I would say, an empathetic health system.
Right. 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 The another question that has been posed in this context is, regarding litigations and laws which are there. Now, you have been part of the human rights advocacies. As a country, we file every year, reports under CEDAW. We have the Universal Periodic Review. So we say we have Domestic Violence Prevention Act. We have Dowry Prevention Act. So we have a lot of legislation that have come up. So, in the context of Protection of Women from Domestic Violence Act, this question is about, when it is diagnosed, or when it is understood that the injuries are due to the domestic violence, even the health personnel are supposed to file a FIR, and take action. So, as educated people, you also have to. That is where the social responsibility, accountability comes. Now, I think is hardly done. So that is the question is, the health professionals themselves do not do this. So what is your reflections and experiences around this? Had they taken one step, to identify, diagnose, and file FIRs, it could have added to preventing domestic violence act is the meaning of this question. Do
Yeah.
you have some reflections around that?
Yeah, yeah. So say whether it's rape, or in the protection of children from sexual offenses, the POXO, or this, I would say that too. The healthcare providers first must ask questions. As I said, I banged, I fell down, but you see certain patterns. There is a syndrome. There's a battered women syndrome,
Mm-hmm.
battered child
Mm-hmm.
syndrome, and you constantly see that. So one is educating them to be able to see that. Secondly, a lot of healthcare providers do not want to go to the court. They do not want to stand there, and so therefore they will also, injury by blunt object, but can you take some narrative from her which we can use tomorrow? Now going and filing an FIR or mandatory reporting of rape or whatever have their own risks involved. If I know that if I go to the health center and they will have to file an FIR, or they will have to file mandatorily report, I just won't go there, especially as we know 80% of sexual offenses happen by people we know, by intimates, people who are related to us or people who live next to us.
Right.
How will I, first of all, to go there, even to convince my mother that something like this is happening, and for her to be able to take a stand, against this whole
Mm-hmm.
structure in the family, I will not go. I will not go if there's
Right.
mandatory reporting. But what a healthcare provider needs to do is to keep all the evidence there. Keep a rape kit. Collect all the evidence. Collect all the evidence of domestic violence. Ask questions. Write the answers. Ask the child what happened. Keep all that ready confidentially. Do not name the person, have a number, whatever, so that when that person is empowered to go to the police or to the courts, you have all this information that is provided.
Mm-hmm.
But we should not scare people. Somebody attempts suicide. Now the whole thing, suicide, attempt to suicide will not become an offense anymore, and I'm really happy about that. But if we say no, 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 this was an attempt to suicide, and I'm going to file a case, your person is in distress. Help the person, right? Help the person to
Right.
understand where that attempt to suicide came from. So I would say that the first job of the health provider is to provide the healthcare. Forget the medical
Right.
legal, that's on the side. And secondly, ask the questions, right questions. And third is keep the evidence, so that whenever the person wants to go and use the law enforcement, you have everything in place.
Mhm. Yeah, I think that is quite an insightful way, because the healthcare provider needs to do first his or her job of saving life, providing medical care. But they can do much more than that if they have this perspective of rights of the person, rights of even as a patient, then they can do much more, which can be useful for remedial measures later. That's, I think, very important. In this context, there is a comment and a kind of a related question. In the broader framework of gender-based violence, more than ever, creation of safe spaces to recuperate after violence or just to express oneself is becoming very important. This is, I think, just reiterating what you have said, that when you
I
have a
fully
survivor, yeah, you have to provide that space. I think you have summarized that in your
yeah, full
yeah.
agreement, full agreement.
Yeah. There's another question
Even
from
to be
Sanjay
validated,
Savle.
yeah, just to be validated that it wasn't your fault, that violence is not a personal issue. I am beaten because I'm dark skinned, but my neighbor who's fair skinned is getting beaten. I'm getting beaten because I answer. This one is so meek. I did not bring dowry, but she got dowry. I didn't bear sons, but she has three sons. All of us are beaten. So the personal is the political. That's what the feminist movement taught us, right? And so therefore to
Right.
say that this is not something that you did, whatever happened, you did not deserve violence. I think that validation
Right.
becomes very important. And we have seen a complete change in the way that women approach the issue the moment you say that it's a violation of human rights.
Right. There is another question from the perspective of let's say malnutrition and policy from Sanjay Savle. The question reads like this: can we say the issues like malnutrition and the policy interventions associated with them also have something to do with the violence against women, family? So, have you found that connections anytime? What are your experiences? And that is the question that is asked around
Yeah, all the
violence. Is it linked to yeah.
Yeah, all the time, Sanjay, all the time. So, the pecking order, right? Who eats first in the family? Yeah, if a man has gone out and he's not there for the meal, the best part of the meal, whether it's the meat or whether it's the vegetables or whether it's lentils, is removed and kept separately for him. But women often in the, in whenever they sit to eat, often they'll pull out a pickle or they'll pull out a chutney, to eat. You cannot cook so much that it stays because they have to eat it the next day. All of us eat leftovers, but that leftovers are distributed equally. It's not just one section of the family that eats leftovers and fresh food is made for the remaining section of the family. That's discrimination, right? So all these, she can't cook so much that it stays, it can't be less. And who's managing and micromanaging this? It is the women in the household. So that malnutrition, right? When vegetables now are costing 160 rupees a kilo, some vegetables 120 rupees a kilo, how much vegetables? So then what do? You add a lot of spice, you add a lot of chili, and you just stretch. Lentils are so expensive. Meat is fish meat is completely out of even what the poor eat pork and the beef, that's the bull or the buffalo meat, uh, that is barely what people can afford, but really not. Within that, what happens? Who gets the meat pieces and who gets the curry? Yeah? Who eats the largest amount of carbohydrate and the least amount of protein? Who doesn't get the vitamins? Who prepares the salad and who doesn't get the salad? Who doesn't get the sweet, the dessert that's made for the meal? So all these have gendered consequences. That itself, in itself, is discrimination and structural violence. But that will impact anemia. I have seen women with 5 grams of hemoglobin. I wonder, how is she even out there? She should be, she should be getting a transfusion, but they're out there doing the. So where are they drawing from? They're drawing from the reserves of their life, from their longevity, from the amount of years they will spend on this planet. That is what they are drawing from, and that is not
Right.
fair, right? So overt, covert, and structural violence, all these are related. So the structural violence of patriarchy, and poverty and caste, and the structural violence of what happens when I fall ill and I'm not able to perform the duties at home, and that leading to violence. And then, of course, what happens when I go to the health center, and there is, what is the permanent cure for malnutrition? Nothing, right? Isn't it?
Right. This is interesting to understand the link between, even a thing of nutrition, cooking, and violence, how they are so closely interconnected. There's a question very close to that. I think this is the last question that we take up today. A doctor insisting on a care plan which the woman, as a patient, wants, but the husband doesn't, is challenging. it could lead to some domestic violence beyond the gates of the clinic. So how do you mitigate that? I'm saying it's a kind of a there are a lot of assumptions in this. Doctor might prescribe something. The husband doesn't, let's say for the example of the doctor might say, now your wife is very weak and two children are enough for you, and plan your family well. So that might lead to more violence at home. I'm saying, I'm just adding my little bit of example in that. How do we address this? Your doctor might be good, well intentioned, but the care plan itself might, as might be having a effect repercussions. So question is, how is there a way to mitigate? What can be done?
Yeah. So, here, first of all, creating a safe space within the healthcare facility. Now, Masoom we have a feminist health center, so obviously it is geared towards that. But centers like the one-stop crisis centers, the Lhasa in Bombay, which was
Mhm.
the first one-stop crisis center in this country, creating safe spaces, creating a ward in which if a woman has undergone violence, you just say she needs to stay in the hospital for a day, and you go and put her in that ward, and so therefore then you can talk to her, or doctors saying that okay, come into another room, I need to talk to you because I need to examine. So first of all is to create that privacy and create confidentiality. Second is to talk to her separately about the care plan. Now this is something that this reminded me that there was a couple who came, and the husband said that when you talk of gender equality, and now we have two daughters, and I'd like my wife to get sterilized because two daughters are enough. The wife wasn't speaking at all. So a healthcare worker, Masoom's, Sadafuli, our healthcare provider, she said, let me just talk to her alone and, kind of convince the husband to go out for a few minutes. Immediately the woman said, no, I don't want to have a sterilization now, because the moment I am sterilized, he will ask for another wife. As long as my reproductive options are open, there is the theoretical possibility that I will bear a son. And then until then, the husband came back. So of course, our health workers, being savvy as they are, they said, you're perfectly right about, you want to stop after two children. If that's your choice, that's great. So, when do you want to enroll for the vasectomy? And he said, no, no, vasectomy won't do. So, this is patriarchy. You're closing the woman's options. What happens after an
Mhm.
earthquake? What happens after a tsunami? What happens, after distress? What happens when the children die in a famine? Immediately getting a second wife, which is possible in patriarchy, to get a younger wife in and get the compensation of all that natural or man-made disasters for yourself. This is the way that women can be sidetracked, but men want to keep their options open. They want to keep the vasectomy.
Right,
They don't want to undergo the vasectomy, right? And women sometimes
right,
don't want the man to undergo vasectomy, because if a tubectomy fails, she gets sympathy from the public. But if the husband is not told that he should use protection for at least 3 months or 4 months after vasectomy, because the sperm stock is already left the scrota, she gets pregnant, and that is what happens. How did you bear this child when I am vasectomized? Even other earlier children mine. That is what women face. So we have to
right,
understand that the choices and the open things that women say they want are conditioned because of
right,
patriarchy.
right,
Yeah, and the structures within which the no choice situations in which we are still trying to make choices and make the best of our lives, and the resilience of people to be able to do that, and the
right,
and the goodness of men and women who try to make a good thing about marriage in spite of all the constraints that it has.
right. So we are at the end of our discussion, but I would like to pose my own personal questions to you at the close of this very interesting conversation, which we could go on and on. I'm saying your 40 years of work, we can't, summarize and synthesize in 1.5 hours. The question that I have is that you wear many hats. At the community level, you have empowered women. We also know that you work at the national, international level at advocacy policy. So now the question is, dilemma is, which should one do more at the community level or more at the advocacy level? Or for you personally, how do you strike a balance? How much you do at the community is very important to empower, but at the same time, you can't only do there. You need to also touch elsewhere, both at the national, state, international levels. So how do you strike a balance and in your both community empowerment person and a policy level activist person? How do you strike that balance in you?
You look like I'm striking a balance and tearing my hair out, so we're trying to see how it can. So I think it's a lot of it depends on your aptitude. Yeah.
Right,
I get bored. I have interacted at the state and national level in terms of policy. It just doesn't light the light in my eyes. It doesn't fire the belly, fire the fire in my belly. I am most happy when I'm working with community. So even my international work is actually national capacity building of groups. Say it could be economic, social, cultural rights. It could be violence against women. It could be the CEDAW, as you mentioned earlier. So how do you understand the CEDAW? How do you apply it in domestic law? How do you
right,
write the shadow report? So it's largely been with organizations that are very similar to Masum. So one is aptitude, where you do what you are best at, and if you do that 100 times and get better, then that's perfect. Having said that, I would say you might do the smallest thing, but your perspective has to be intersectional. Yeah. So when I'm
right.
working, am I hurting the interests of another group when I'm working here? Even if I'm very angry with a man, okay, because he has beaten his wife, or he's raped, do I allow the police to enter the house without a warrant? Yeah. Do
Mm-hmm.
I encourage the police to torture this man in police custody? Do I humiliate the man by publicly humiliating him? Then how are we different? The wife's power, the man's power, and our power, and the state power is much more than all our powers combined. So we know that violence happens because of power and control. And if we use
Right,
power, we have to use power that is collective. We have to use power that is empowered, power that is conditional to what you behave and what you do. It is answerable to communities, not just to donors and not to the state in terms of compliances, but the primary answerability of communities is to people. We ask health systems questions, right? Why was the health center not open? Why can't people ask questions about us? Why are we the holy cow? That we think that we are the best people. No, changes don't happen with funding, they don't happen with donations, they happen with a lot of people working together. So one, aptitude, what you're best at, and second, even if you
right,
do the smallest action, to see that you have a global perspective of inclusion. And inclusion doesn't mean tokenistic, having one person from one community and the main narrative or the
right,
discourse on the platform being that of for those who come from powerful intersections, but unlearning and learning, and learning from those who have lived realities of having faced
right,
violence. I have felt that theory informs what you do there, but knowledge is created through the sweat of people, and that informs the theory. So I think
right,
if I'm happiest with communities, I'm happiest with doing capacity building and training, and I found that if I do that best, I can do my bit.
right,
But there's some people, friends of mine, who are excellent at policy, they're excellent at asking questions here or at the UN, and I think they should continue doing that.
right. Yeah. Thank you, Manisha. We are running out of time. I am sure it has been a very interesting conversation. I do not want to summarize what you have said because that will be a injustice to what you have said. You have summarized it very well at the end about power, about how do we transform societies. Change is a process that they engage at different levels. Some those who have aptitude and who have flair to work at higher levels, they should do that with a more transformational lens in their mind, and with the keeping upholding the rights of the communities. And those of us who are good at working at the community should continue, and more should join hands there. And I'm glad that we were able to, through the encouragement of our university, to bring this issue of violence against women to the forefront of discussion. We know that this discussion does not happen in many spaces where it should happen, especially, let's say, medical schools or public health discourses, public health education. So we hope that this conversation continues in various rungs of society, various domains, various institutions. And thank you very much for giving us your insights and clarity on this issue, and why all of us need to combine rights, perspectives of accountability, perspectives of transforming institutions, and perspectives of making safe space for everybody. So even you said that to make create space for women, we also need to work at transforming men, and raise their consciousness towards their accountability to women. I think there is a wide range of intersectional work that is required, and I'm very grateful that you could make time. And from all of us from the Zimpim University Public Health team, thank you for making time and giving us such a thought clarity on this issue and bringing us your experiences of so many years. Thank you very much. Yeah,
Thank you. Zindabad
and
to
we
everybody.
thank all the
Thank you,
participants.
APU, and all participants who came, and
Yes,
thank you, patience. Thank
we
you
had
very
we had
much.
more than 400 registrations. Quite a lot of them, attended this conversation, and we will be sending this link to all those who registered and others that it is also will be on our website. So this is like a conversation that will continue, and we hope it is the beginning of many conversations that we hope that should happen both within Azim Premji University and elsewhere, and that is where we thought we can make a contribution. Thank you so much. So thanks all the audience and participants. We close here. Yeah, so we will be in touch with you.
Thank you so much.